and today we are going to talk about a very grave condition of the eye in which you get actually perforation of the cornea. And this happened in this patient because of a corneal ulcer which could not be completely healed, and it led to that perforation. So if you just look at the cornea is a 5-layered structure, and if you see over there, and if there's an ulcer, there's infection of the cornea over here, then this cornea starts to come thinner. This area will erode away or melts away, and then it becomes even thinner over here and then keeps going over that way. So I'll just make that again. If you have, this is the cornea. If it becomes very thin, it will go all the way right to the descemes membrane at the end, and this will produce an area of protrusion of the descemes membrane. This is called the descematocele. So this, you can gauge the depth of the corneal. This is here, we're coming about 50% depth over here. This is 90%, 95% depth of the cornea is gone in this patient. And at the end of this, you are going to get a hole in this cornea. And if you go behind this, you can see the eye is going to be having the iris at the back of this. If I put the iris over here like this and superiorly over here, then as soon as this perforates, the fluid is going to go out. And as soon as the fluid goes out, this iris is going to bow forward like this, because the anterior chamber just becomes flat. And this iris over here, this will come out, and this will prolapse through the this opening over here, and this produces this area of perforation which you're seeing in this patient. This brownish tissue you see over there, that is the iris which is prolapsed from the eye. And in this area, the anterior chamber will show on the slit lamp is all collapsed. The iris is just touching on the behind the surface of the endothelium. And if you leave this for a longer time, you will get adhesion formation because of the perforation. Obviously, you can see the iris is exposed to the environment over here. It becomes inflamed, and it will get uveitis on its surface. So let's look at the video and how it looks over here in this patient. And you can see this is the slit lamp picture, which shows you that the patient has got ciliary congestion. The patient, as soon as he gets that perforation, he'll say that there's some fluid which came out, and after that I couldn't see anything because it was a prolapse of the iris in that patient. On magnification, you can see that this is the iris over here in the center, and this is the slit lamp examination showing you this view. This is the other eye of that patient. He was pseudophakic in the other eye, and if you look in this side, this is the iris which is sitting over there, and after a few days it tends to produce a fibrin over here, and it produces a pseudo cornea in these patients, which will look like as if a new cornea has evolved over that or grown over that area. And eventually you will see a covering of that pseudocornea with a bluish or brownish tinge at the back, and you will call it an anterior staphyloma. Well, the question is, what can you do for the patient? Well, it becomes an emergency for the patient. That, as I would just make it similar to what would happen if you have a tube in the car tire, and if that punctures out, then you get that tube hanging out from the tire. So you need to repair and plug it with a patch. So what can you do with that? The patch is exactly what you call is a patch corneal graft. So you will take this friable cornea out from this area, and instead of that, that tissue will take a donor cornea, a fresh donor cornea, or which will be a clear cornea. If you don't have that available, you can get a tectonic cornea, which might be an opaque cornea you can put over here, and then you need to stitch that cornea with that hole so that the patient's vision can be restored in these patients. Very rarely, if you do not have that cornea available, you might consider taking this conjunctiva over and just attaching that with a base of sclera in that area. If you get that small pieces of sclera from donor tissues along with this. But that is, if there's no availability, the treatment of choice is a tectonic graft. If the patient has an infected area, then you probably need to remove that frill of infected area before you put in these patients. And these patients, you need to preempt that perforation. And if it's going to happen, you need to organize everything so that it does not happen. And you can reduce that, because sometimes if this becomes the case, in this case, sometimes it's very difficult to manage. And the most difficult complication you can get along with this is endophthalmitis, because the organism can grow directly into the eye through this area. So it's very crucial to pick it up. And we hope that you like this video. And if you got something out of it, do hit the subscribe channel and the like button. Thank you very much for watching.